in the planning of the musculoskeletal module and involved in the initial train-the-trainer sessions. And I understand that this is to be a make-up session for those of you that had missed the first train-the-trainer session and were interested in being involved in the second train-the-trainer session. So to that end, before we get to introductions, just a bit of a disclaimer. I'm not a musculoskeletal specialist, rheumatologist, sports medicine person, orthopedic person, anything like that. I'm a regular family physician and don't particularly even have any expertise or long experience in anything to do with MSK other than what the rest of you have, which is that we see lots of MSK things in our offices. To that end, what I'm hoping for here is that I want to be able to present to you the things that I learned and the things that I felt were of value to me, and absolutely encourage your feedback and participation. Please feel free to interrupt me at any point. I am going to be asking questions of you to get your feedback. What I'd like you to look on this presentation with is a very critical eye to really see what in here makes sense to you and what it is that you feel is relevant for your real-time practices. We'll be presenting a lot of different tools, some different suggested workflows, and trying to get through things in a reasonable amount of time so that we don't kill you. I can't imagine me talking for 3 hours, so I will do my best to open this up for discussion at any and many points throughout this presentation. So that being said, I'd love to know who's on the line and how many physicians we have and who of those are family physicians, what other support staff we might have, and to see if there's any other specialists or other people such as physiotherapists or anybody else that might be involved in musculoskeletal that is here because of interest in this. So
Bruce, do you want to start from the top of the list, or?
That would be perfect. And I can just call out a name, and anybody that's associated with that name that's at the same site, I'd love to know who you are. So first I have at my top of my list is Cindy Kadzuika.
Yeah.
Sorry.
That's okay. Cindy Kadzuika. I'm in Dawson Creek. I'm a new practice support coach, and I've been in this position since May and have not had any exposure to the MSK initiative, so this is a learning experience for me.
Great. And is anybody there with you, Cindy?
No, it's just myself.
How lonely. Denise Smith.
Hello, Bruce. It's Denise Smith, Regional Lead for Northern Health. And just to add a little to Cindy's comment there, Cindy is the equivalent to the provincial coordinators, the practice coach, and we're really happy to have her in Dawson Creek. You're right. And she's doing some awesome work there. So I'm basically on the call just as a refresher and just to help support any of the many people who inquired about this makeup session, and hopefully they will all be on the call.
Great, thank you. Elizabeth Berlin.
Elizabeth is on mute, I think. Can you unmute?
Elizabeth, we can't hear you. I'll get back to Elizabeth in a second then. Jacqueline Martin.
Hi, this is Jackie in Kitimat. I'm the practice support coach for this community.
Hi, Jackie. And Jane Core.
Hi, I'm Jane. I'm the newest member of the practice support program here in Vancouver, so I'm just joining in last minute.
Great, thank you. And Catherine King.
and practice support coach in Burns Lake, and I'm just on for a bit of a refresher.
Okay. And Kelly Picard. Kelly, you may be on mute. We can't hear you.
Oh, there we go. Sorry, can you hear me now?
You bet.
Okay, so I'm the new practice support coach here in Massett. I just stepped into my role in August, and this is sort of my first introduction to the MSK.
Okay, thank you. And Manjo Singhal.
Oh yeah, it's Manoj Singhal. I'm a family physician. I used to, in my past life, I used to do consultancy-based chronic active pain rehabilitation, which would be a branch of physiatry, as well as consultancy-based psychiatry. And so we do a lot in our medical clinic in terms of chronic pain or musculoskeletal pain in addition to psychiatry. But it's a part of our everyday practice and general family practice.
Great. So you'll be a great resource if there's some questions around pain and some of the things around that, which would be excellent for us, if you don't mind. Thanks, Manjo.
Not at all.
I'm volunteering you whether you like it or not, you notice.
Yes, no, I'm fine.
And where are you based, Manjo?
It's Manoj.
Oh, sorry, Manoj, sorry.
It's in Richmond, BC.
Okay. And Nancy Smith.
Can you hear me?
You bet. Yep.
I pressed the unmute mute button before I heard your response. So I'm the practice support coach in Prince Rupert. I've just started working in this position in July, so like Sydney, this is my first exposure to a train-the-trainer session.
Okay. And Sarah, you might want to introduce yourself.
Yes, I'm the project manager with PSP, and I work out of the office in Vancouver.
Great. And Sharon? Sharon, are you still there? You might be on mute.
Sharon is on mute. I'm not now. Okay, so I'm a practice support coach here in Mackenzie, and I have been working in this position since 2011. And currently, besides being practice support coach, I am the clinic lead for a doctor's office here. And we're an integrated system, so I have 5 physicians and a nurse practitioner, and working in that office as well as this job, and looking really forward to the MSK module.
Great. So the only person I haven't heard from that I have listed is Elizabeth Berlin. Are you on yet, Elizabeth?
Just to let you know, by the way, this is Jane talking. Elizabeth Berlin has sent a message through, I guess, that little splash screen where you can type in your questions.
Got it.
And she's saying,
yep.
Sorry, I can't seem to unmute. I'm a family nurse practitioner in Burns Lake area, and she does a lot of MSK.
Perfect. Thank you. Elizabeth, if you can hear me, that's a sneaky way to get out of answering any questions. Are there any other people that I've missed that aren't listed on the list that are attending this session?
Lee Cameron, Bruce.
Yep. And who's there with you, Lee? Hello, Lee. Can you hear us?
Yes, we can. Can you hear us?
Now we can hear you, yes.
Okay. So I'm Jenny Lee. I'm a family physician, and I completed the mental health module. This is my second module. And I work with the United Church Health Services, where we have 6 other physicians and a nurse practitioner. And with me today is my assistant.
Hi, Trish. I'm an MOA for Dr. Lee here in Hazelton.
Hi, Trish. And is there anybody else on there besides Lee?
This is good. And just to introduce myself, I'm a practice support coach, Lee Cameron, and working Ridge Memorial Hospital in Hazelton, and it's good to be here today.
Just you?
Yep.
Okay.
Have you
And
received the slide deck yet?
Just got them opening. It looks like they're opening up here. I'm just holding my breath just because I'm a little.
Okay.
Here we go. Yeah, we're rocking. Thanks, guys.
Great. And anybody else out there? So it looks like that we have two family physicians, Manoj and Jenny Lee, and one MOA, Trish, and the rest of you are all involved with the EVO Practice Support Program. So welcome, everybody. And some of you for the first time. So that's great. And again, you know, I really want to emphasize this. I don't want to be talking for 3 hours. And certainly people like Manoj and Jenny, I'm sure that you've had some experience in dealing with some of these things, and I'd love to hear your feedback as we go along. And for the practice support people, certainly feedback that you've heard, and if you've been involved through other modules, how the feedback from those modules might inform us on this module. So with that being said, I'll plunge into things here. What we're here for is that it's been recognized that there's been some gaps in care, especially as relates to rheumatoid arthritis, osteoarthritis, and low back pain. And that this was felt at a provincial level to be something that was important to explore and to try to provide a consistent approach for these conditions and to provide some, I really hesitate to say the word guidelines because I don't like the word guidelines, but some resources and support and tool in being able to help family physicians both deal with these conditions on a more uniform level and to be able to work with specialists and other allied health professionals in being able to have a uniform approach to these conditions. And that doesn't mean that every patient be treated the same way, but that we understand each other when we're talking a certain language about low back pain, rheumatoid, and osteoarthritis. So if people were expecting that we were going to be talking about musculoskeletal injuries or anything outside the scope of these three conditions, that's not what the musculoskeletal module is about. It's too big to tackle other things like sports injuries, rotator cuff tears, you know, and other forms of arthritis or other conditions such as neck pain. We want to stick with these ones for now and do these well. And if there's an opportunity in the future and it's appropriate, then we can deal with other things. And so we're going to just move through the different tools and workflow and get your comments on that. Does anybody have any questions on that? It certainly was something in the beginning that people were a little surprised about when we said MSK, that we were only dealing with these three conditions. Anybody, any comments or concerns about that?
Could you just review what are the three conditions that we're dealing with then?
Rheumatoid arthritis, osteoarthritis, and low back pain.
Okay.
And to some degree, the rheumatoid and osteoarthritis have a common approach, and certainly there's an an overlap of the tools between low back pain, rheumatoid, and osteoarthritis, especially as to do with pain and self-management, which we'll get into at a later point in there. So there's been an amazing amount of work done on this. When I first joined the project, I was in a room with about, 120 other people. There was a ton of people, specialists from all over the place, from orthopods to rheumatologists to people that were physiatrists, pain specialists, family physicians, and everybody. And certainly, too, there's a lot of input from some evidence-based practices, a lot of what came out of Alberta and New Zealand with the low back pain and United Kingdom, and a lot to do with the BC guidelines and some of the framework around the rheumatoid arthritis and osteoarthritis came from that area. You know, what we want to provide is just some very practical and simple tools that can be used in the family physician's office. Manoj, are you on an EMR in your office?
Yes.
Which one are you on?
We've got our own custom one. I was actually just prior to this demonstrating it to one of our locum physicians. It's called Chart Plus. I was actually incidentally just going over some tools for back pain and so on. Just
Excellent.
And I'm not knowing that's what we're doing today, but that's what we were doing.
Perfect. So this is a perfect segue into things here, or you segued into us perfectly. How about you, Jenny? I think you're on mute, Jenny. I don't hear you.
Go ahead. Our office is on MOIS, so that's the EMR that is used throughout the NHA.
Yep. In some exceptions, up in Rupert, I know there's a couple others. Kitimat has a couple others as well. But certainly MOIS is used a lot. And for you, Manoj, it's good you have some tools. We may not be able to help you with be able to integrate some of the tools into your EMR, but Jenny, I've worked with this project. We've worked with Bill Clifford and the programmers up there, and we're making every effort to have all the tools and the workflow and all the quality indicators and the measurements built into your EMR so that you can use those tools and that they can be used for some reflection and feedback. So for all you other PSP coordinators out there that are involved in MOIS, physicians that are using it, that's something that should be in place prior to our session, the second Train the Trainer session.
We have a folder where even if it's paper-based, we can scan it if it's a tool that we use, and we do that quite a lot. But
great. So
yeah, we have also computer.
Go ahead.
Yeah, that's fine. Yeah.
Yeah. So we'll get all that information to you, Manoj, and have all the paper-based tools and handouts and the algorithm, which is in a hyperlinked PDF form to you, so you can use that. And sorry, and then the things that I found that were really important besides the tools, which to some degree some of them are helpful for me in especially in inflammatory arthritis, in being able to guide my care. Some of them are reminders to me, especially the things that are the red and yellow flags that are associated with any of the arthritises and or back pain. And certainly there's some good tools that possibly, Manoj, you may be familiar with in dealing with complex and chronic pain, and some really neat stuff that's involved with some of the self-management. And I'm going to focus on the brief action planning at the end that I've really taken a real liking to in my office, and I love using it with patients with all sorts of things beyond the scope of the actual rheumatoid, osteo, and low back pain. So we're going to move through those things and give them to you. The things that are challenging for me as a care provider, and I'm sure Jenny and Manoj, you can echo this, is that, boy, when I see somebody listed on coming into my office that it's labeled as low back pain, and I know it's somebody that I've been seeing for a while with low back pain, and it's chronic, and there's maybe a bit of sciatica, or there's some other radiculopathy, my stomach sinks a little bit sometimes. And certainly with the pressures we're getting from patients to do imaging and more advanced imaging is high, and the effect that the chronic pain in general, and specifically low back pain, has on their psychosocial and work needs is tremendous. And I found, and certainly one of the things that we're not going to address in great detail here, but there's a lack of, okay, what do I do next, and how do I help this patient besides just sending them off for some therapy and tell them to do some exercises. And one of the things that we're going to be looking at in the next Train the Trainer session is that we're going to be having Dr. Hamilton Hall presenting, which is wonderful. He's the back talk doctor, and he's the proponent for looking at patterns in back pain. So whether or not it's a mainly back pain or mainly leg pain, and the different kinds of exercises that you can do and work on based on that kind of a differentiation.
It's interesting that you say that. Manoj speaking again.
Yeah.
In our tools, we have Dr. Ferrari, and we've been using Dr. Hall's criteria for many, many years. Those are part of the things we were going through earlier.
Perfect.
So very interesting to note.
Yep. And I think, you know, what's neat for all the practice support people that are involved here as a way of really engaging doctors. Most of us doctors know Hamilton Hall. I can remember back 30 years ago when I first started practicing the WorkSafe or WCV back then, books on back talk that were out and I was giving to patients that Hamilton Hall developed. And so he's done a lot of work on this, and it's supported right across the country, and more provinces are actually taking on his work. And Jenny, you've heard of him before?
20 years ago when I first came out in practice.
Yeah, and you remember that back talk book that we used to get, that red one that came out possibly.
I think WCD came around Hazleton at that time and gave us copies of the book. And
yeah, that's the one. And you know, as something that legitimizes what we're doing and really perks physicians' interest is mentioning that Hamilton Hall is going to be involved in this and is going to be presenting. And speaking to him, he's an absolutely amazing, vibrant guy, and he's just got a passion for this. It's incredible. So that's going to be pretty neat. And other things that are really problems with us is that we just don't have some of the tools to properly assess and we're bombarded with different recommendations as to, you know, whether we should do a certain straight leg test and what degrees it's positive or negative at, and whether or not we do another test called a Faber test, and on and on and on for different things. You know, how many joints are hot that make it important to pay attention to and we get excited about. And then certainly finally two huge areas that probably drive most of us family physicians crazy are the relation of the injuries and musculoskeletal problems to work issues, how we deal with employers, and how we get people back to work or deal with them being off chronically long-term work, and finally dealing with medications. And Manoj, I'm sure that you've seen this time and again and had to deal with this in many things that you've had to do with your experience.
Oh, absolutely. It's a very common occurrence. I'm not as pessimistic or heart-sink about the issue. I do find that with patient education and with the right way of discussion, that some of those issues do fall, meaning that imaging is not necessarily needed. And if said the right way and in the right context, I find patients they get that. They don't say, oh, I do need an MRI, especially if it's a very low likelihood or practically zero likelihood of surgical needs. It tends to be an expensive picture. So I think that communication sometimes needs to be made, or to be decisive that if that's the case. Sometimes that's a phenomenon that occurs, I find, when we work with these patients.
It's incredible that fear is such a driving force in many of the patients' expectations, needs, or requests. And fear not only around, you know, oh God, am I going to be disabled forever, to fear of, is my doctor going to cut off my medication? It's the only thing that helps. And dealing with that through education and self-management techniques is a huge piece of dealing with any of the MSK disorders that we're going to be talking about today. And that leads us into, of course, the patient barriers of, as Manoj mentioned, having that education to be able to explain to people why we're not going to go to an MRI when you just hurt your back yesterday, when there's no signs or symptoms that need to be investigated. A huge piece is that I don't have money to be able to go to a therapist. What can I do by myself? And all physiotherapists are not created equal. There's some physiotherapists that are very good at dealing with MSK and especially low back pain. Others that specialize and are better in other areas than that. And probably another thing with patients is self-management is something that's catching on. Perhaps we as physicians aren't as aware of it and don't teach it as well as we could. It's certainly something that as a technique needs more focus and time spent on it with patients if possible. As I mentioned about the fear of not being able to have medications, how you're dealing with work, and understanding about what the symptoms mean are all really critical pieces. And that final piece down at the bottom is something that isn't going to be dealt with as much here other than with the shared care piece and speaking the same language and knowing what's appropriate to move on up the ladder to somebody more specialized in their care. And then finally, you in Northern Health, count your blessings that you've got MOAS and that your health authority and the different people in administration recognize that interoperability and being able to communicate is critical. And certainly being able to have a common approach, and which is not mentioned here, is having an environment of being able to use self-reflection to see whether or not that actually can support change. And certainly up in Northern Health with MOAS and some of the things that Bill Clifford has led on through AmCare, which is a piece that helps you do that self-reflection, is really critical. So one of the things when we went out in looking and talking to docs to find out what people knew and didn't know is that we really came up with some lists of different things that were important and things that were pretty common knowledge in there. And so what we're going to try to focus on today is touch lightly on the things that people know and look a little bit more in depth at some of the things that people in general don't know. And I think that's an important slide to get people's feedback on. And both Jenny and Manoj, looking at that list, and Manoj, you may be a slightly bit different because you've had some expertise in it, but does that strike you as being a reasonable list of the knows and don't knows in family practice?
It seems reasonable. I would definitely add anxiety to depression, but yeah.
And how about you, Jenny? You come from a little bit different approach than Manoj would be, who has specialized more in these areas.
Yeah, both lists look great, but what I've been doing for the past couple of patients who had really, well, they had to be ruled out for spinal stenosis, I've actually been sending my CT scans to a neurosurgeon and getting his opinion, and he's been faxing back his recommendations. So that's really been helpful for me.
Wow. Hey, Jenny, you should save that one and share it at the train-the-trainer session coming up, because that's exactly what shared care and communication should be all about. So that's very impressive. Well done that you've done that on your own and found somebody that you can do that with.
That's a really great example. I'm wondering about neurosurgery and the race line. That would be, yeah. I mean, that sounds like a really great thing to have on the race line. That sounds like a very rate-limiting difficulty of getting that kind of assessment. for most practitioners.
Jenny, was that?
I
Sorry,
would-
go ahead.
For me, the race line doesn't work all that well for me. I've had a previous relationship with the neurosurgeon, so it's easier for me just to call his office.
Oh yeah, no, that's wonderful. We do that as well, but I'm saying that it's not widely available for certainly in the Lower Mainland surgeon to do that. Like the spinal clinic, for instance, they won't do something like that. They'd really want to see the patient. But what I'm wondering is if at some level it might be a suggestion to the race line or others to have neurosurgery or even orthopedic surgery with interest in the spine to have that same service.
Yeah. Jenny, one question for you. When you do this, do you use the billing code for being able to get specialist consultation, telephone consultation with him?
I'm not sure. I think you'd have to ask him because wouldn't he have to bill?
No, you can bill as well in that. So when you're
I'm a contract physician here, so the GPSC extra billing fee code apply to me.
No, they wouldn't. So that is interesting, though, because I think it's something for the PSP people to understand there that what Jenny is doing in being able to get a telephone consultation, much like Manoj has mentioned with the race line, is that family physicians who are doing MSP billing can actually bill a fee code, as can the specialists that are receiving the call, as long as it's not involving a setting up a referral for transfer of care. So the assumption is that by doing this, you're saving the system a transfer of care and consultation fee. So it's worth being able to have the telephone consult fee for that. So that's something to note for the PSP people, and it's a good point that Jenny brought up about that, and Manoj about the race line. So what we're going to just jump into first is looking at being something that's a little less contentious, rheumatoid arthritis and osteoarthritis. And I say that just because low back pain tends to be something that as family physicians we see a lot of, and there's going to be, to some degree, perhaps some resistance, even though in the face of a challenge in dealing with low back pain, people are often set in their ways of how they practice and deal with patients with this. It might be a little bit of cognitive dissonance if they're not practicing perhaps in the way that is most beneficial to both themselves and the patient, but it's tough to change those kinds of habits. Whereas in rheumatoid arthritis, generally you'll find, in my experience, most family physicians are quite uncomfortable in taking on some of the complicated care involved, especially with the medications, and often in determining or differentiating the differential diagnosis to decide that something truly is rheumatoid arthritis or not. Would you agree, both Manoj and Jenny? Is that sort of straight home?
Sure, but I do telerheumatology in Hazleton.
Yep. So you're a little bit like Manoj is with the musculoskeletal. You're a little bit of an aberrant physician that is comfortable in that area.
Bruce, was your question about rheumatoid arthritis, I kind of didn't quite get the gist. Was it that family physicians may not be comfortable in assessing rheumatoid arthritis?
They may not be comfortable in the initial diagnosis, in my experience anyway, may not be comfortable in the initial diagnosis and the treatment, especially with the DMARDs with rheumatoid arthritis.
One question to ask is, there's 7 criteria for rheumatoid arthritis.
Yes.
One question is basically, can you hold a coffee cup in the morning without your hands being excessively stiff for an hour? And that gets 3 of them. and then there's X-rays and nodules as 4 and 5, and then there's a couple of others. So I mean,
so we'll go through some of those things as what the rheumatologists decided were the criteria that they'd like us to see, and certainly that's a good point, Manoj. I mean, there are some very specific criteria. All I'm saying is, in my experience, family physicians may not be as comfortable in diagnosing those things.
I totally agree with you, and I think some physicians have more comfort than others, but I agree with what you're saying.
Yep, yep. So, the critical pieces around why we have some guidelines and suggested treatments are that in rheumatoid arthritis, the rheumatologists say we're not diagnosing and managing rheumatoid arthritis early enough, and therefore it's resulting in more disease damage, more complications from other comorbidities that are affecting the condition, and ultimately we're not monitoring how stable the disease is. In other words, as family physicians, we can do a better job in being able to figure out what's going on, prevent damage to the joints, deal with the other health issues, and make sure that things stay stable. In osteoarthritis, what the orthopedic surgeons and rheumatologists tell us is that what they're finding in the patients is that we really need to emphasize improving function and deal with the patient's pain, be conservative in our care, however, not wait too long. So, they often will see people with hips and knees that have degenerated to the point far beyond what should have been dealt with in a timeline, and that people should have moved a little bit earlier, because getting into wasting of muscles and other joints being affected because of a limitation in movement is a critical factor. So those are the reasons that they felt that we need to deal with these kinds of things. And really, some of the things that Manoj was talking about in there in looking at rheumatoid arthritis is being able to differentiate a joint that's inflamed and a joint that isn't inflamed. And we've been given some very set criteria around those different features of joint pain, swelling, deformity, redness, warmth, and morning stiffness. And Manoj, what the rheumatologists felt, according to the guidelines, was that 30 minutes was the critical time defining limit, that if someone had stiffness in the morning for more than 30 minutes, it was suggestive of inflammatory arthritis.
Sure, yeah. Significant. 30, yeah.
Yeah. So that was an interesting, and 60 was mentioned. They felt that that was where we should go. And that the interesting thing, of course, that within an inflammatory arthritis, such as rheumatoid, versus a non-inflammatory, such as osteo, having other symptoms, and especially I find with patients, is feeling fatigue, just wiped out with an inflammatory arthritis. They're really tired. And so that's something that are things that are differentiating between that. And Jenny, one of the things that we did when we were embedding all this into our EMRs is that one of the very first questions when people are looking at a joint, beyond the red flags of things that could be like a septic arthritis, an infected joint, is trying to decide whether something is inflammatory or non-inflammatory through a checklist, a reminder list. And it sort of forces people to pay attention to these things and to comment on them, and to actually take a look at the joint so that they can record whether it's red or swollen or whatever. And so when they're looking at rheumatoid arthritis, the recommendations are, as I'd mentioned before, being able to identify that it is inflammatory, that it is rheumatoid and not some other inflammatory arthritis, going through some early and specific testing investigations, managing it properly, and then taking care of it and always remembering the effect that rheumatoid arthritis can have on other diseases and the implications that rheumatoid arthritis itself is a chronic disease. And those were things I think that were very important. And there's the roles that we can play in primary care. And one of the things that I found is that by using the tools that they're suggesting in here, certainly now that I can speak the language of the rheumatologist and be able to say to him that I'm seeing certain things and that there's this many inflamed joints and I've started a patient on this kind of medication, certainly get a lot more respect from them and willingness from them to acknowledge that maybe I do know what I'm talking about and that they would be quite willing to work with me with the DMARDs. And Jenny, I'm sure you find that in your role, that when you deal with rheumatologists, because you are that outreach person, that they pay attention to what you have and it works quite well. Do you find that?
Oh, of course. Like Dr. Howe is the one that I can always call with whatever questions I have. Of course,
Yeah.
I teach medical students as part of my practice, and I find that none of them know how to examine joints properly.
And so one of the things that the rheumatologist mentioned, and to precisely that point, is that you can do a joint exam looking for all the hot joints quite quickly and very efficiently in the context of a relatively short visit. And that's what the family physicians will complain about. How can I check everybody's joints in a 10, 12, or 15-minute visit and do a proper job of it? And the rheumatologists tell us that we can. And so there's actually, as a tool, a little video that runs through a full joint exam that's quite slick, that one of the rheumatologists had provided for us at the Train the Trainer 1 session that can be shared with your physicians when you're actually using this and presenting to your communities. And also some patient education tools that we'll get into it in a little bit in here.
I have to admit, Bruce, I also just phone our local rheumatologists, and we often start treatment even if there's a long wait list or they feel comfortable
Yep.
with the history that's given.
Yep. And I think that comes from that trust, right, Manoj? They know that you know what you're talking about and that you've done the right kind of exam and paid attention and done the right tests. So they trust you. And that's what I'm finding is happening now that I have this information, that the rheumatologists are very willing to work with me. Osteoarthritis is a little bit different, and the things in osteoarthritis that the rheumatologists and orthopods say, as mentioned before, about early diagnosis, but that the x-rays may not correlate exactly with the degree of the functional effect that the patient has. I have patients that have, by x-ray, quite serious osteoarthritis, and yet are very functional and active. I have patients with really minimal x-ray findings who are quite disabled by their osteoarthritis. So the point with the x-rays is that other than making sure in some situations that there aren't other things going on, especially the joint being eaten up by an inflammatory process, that the x-rays may not correlate well with the degree of disability that the patient has. So that's one thing that I think was a key message that went across to the physicians in there. Would you guys agree out there?
It's absolutely true. Yeah.
Yeah. And so accuracy in diagnosis, keeping people functional, and doing the appropriate investigations to rule out other things are important in osteo. And again, with either osteo or rheumatoid, patient education, rehab, medication, and referrals are the critical pieces that we need to focus on in here. And this was an interesting reference that I found that was from the National Health that was talking about indications for surgical referral and the difference in especially people's expectations when joint replacements are needed versus the knee just being cleaned out. And I think this is a good way of sort of looking at the difference between those two and being able to discuss with patients around their expectations. What I found really interesting was a 1994 reference down at the bottom that came out that said that in most cases, in 95% of cases, a replaced joint will last for 15 years. Now that may have improved now, and I don't know, Manoj, you might be, or Jenny, any more familiar with any more recent studies beyond, more recent than 1994 to say anything different. I keep hearing that number 10 years being bandied about, but this was an actual study that was done that said, in fact, actually it's a bit longer with 95% of the cases.
And my understanding also is that technology gets better and that
Yep.
a lot of the patients are getting, or before it used to be, you have to wait for a certain age, and that's becoming less and less of a, it still should be thought of, but it's becoming less and less of an absolute, is what I'm seeing.
Exactly.
Yeah.
Yeah.
My problem is that here in the north, it takes a year and a half for a patient to actually see the orthopod, and then it takes another year and a half before they can get their surgery.
Yeah, you know, we're so very fortunate down here in Vancouver Coastal because we have that program, the OASIS program. Have you heard of that, Jenny?
Yeah, because I started sending a lot of my patients to Vancouver because they can get access to quicker consultations and quicker surgery.
Yep. And the OASIS program, for those that aren't familiar with it, is a rapid referral program for knees, for patients with knee and hip arthritis who are on a path to possible joint replacement. But it goes beyond just yet providing rapid access to the surgeon. It actually has incorporated into it a very extensive educational and assessment program. And so they will see patients based on what the physician feels their patient fits with a priority. And I've had patients actually have a joint replaced as quickly as 3 months from the time of the referral. And of course, I should be a little bit embarrassed to say that because that probably meant that that patient didn't go nearly soon enough and in the course of their osteoarthritis. But the educational program that they have that's associated with OASIS is excellent. Have you ever used that, Manoj?
Yeah, actually one of the hats I wear is for our division is the continuing medical education lead for orthopedic surgery. And so at the end of this month, we'll actually be having a program of which I'll be emceeing, where it's an education, all the physicians in our division will be paid a session, or not a session, an hour, I'm sorry, of sessional rate. And we'll be bringing in the RACE line, we'll be bringing in OASIS, and an orthopedic surgeon precisely around what you've just discussed. And so the idea is to bring this more educational ideas out to the general group of family physicians in our division, what's available and if they're using it. So we'll actually be polling. I intend to poll non-formally with the group. But yeah, we use OASIS all the time, and by all means.
Yeah. Yeah, so good pickup, Jenny, be able to realize that that's a valuable resource from anywhere in the province, as long as patients are willing to make the travel and the trip down. It's certainly a good program. And I believe now RACE is available province-wide. However, there may be some of the specialists that are only available to Providence Health and Vancouver Coastal. Do you know any more about that, Manoj? About the ones that aren't available provincially?
Well, I don't think, I don't know if they're available provincially, but I think there's some, like we've discussed earlier, I think there's some services that are not available, period, where you're kind of phoning who you know, maybe.
Yep. Yep.
And so I think orthopedic surgery is not one of them on the race line.
Yeah.
And so living in the Lower Mainland, I may phone to St. Paul's or having patients with the Canucks, I might have some folks I can call who do work with the Canucks and that sort of thing. But it's not available to everyone, and the rapport isn't necessarily there. But I wonder if that's something that should be more formalized for everyone, in the spirit of the race line for the other services.
We have a document in the tools that lists the most recent list of specialists that are involved in Raceline and who can contact them, and I'll show you that in a little bit. Jenny, have you used the Raceline at all?
Not at all.
Have you heard about it?
I think I received something in the mail, but again, haven't.
Okay. And Elizabeth just said from Burns Lake that she uses Raceline in there. So that's it's good to hear from up there that you do as well. You find that useful, Elizabeth, when you've used it?
I have. I haven't used it many times, and we were kind of using it off the radar because it wasn't formalized then for the North. But I understand that it's being rolled out now, and we actually have a meeting next week to discuss how that can be used here in the community. So.
Perfect. That's great.
So, can I
yep,
ask
go ahead.
about OASIS? So you're saying that this program is accessible to the whole province. Is it a publicly funded program, or is it privately funded?
It's funded through Vancouver Coastal Health. Now, there may be ministry funding as well through it. I would suspect there would be. I mean, essentially, it's all coming out of the same pot. However, I believe its main source of funding is through Vancouver Coastal and possibly Providence. Manoj, I don't know if you know any more about that.
I'm not sure about the funding for all of that. I don't really know.
And Jane just piped up. Jane Corr said that it is a Vancouver Coastal project.
But does that mean that a patient from the North would have to pay to access the program if they can get there?
We do take referrals from the Fraser Fraser Health as well. Basically, whoever can get to us. We won't. I don't believe that we have criteria for turning people away. Having said that, though, it is the only program of its kind. It's not. There isn't a counterpart in other health authorities, as far as we know.
And Jenny, you said you've used it. Have you had any patients turned away?
No, I haven't.
Yeah, so I think they probably wouldn't advertise the fact that they don't turn anyone away or advertise in other health authorities, or otherwise they might be swamped. But certainly it's one of the best examples of a rapid access, well-organized and coordinated program that I have ever seen or been involved with.
We've done outreach programs up to Powell River and such, so
yeah.
Wherever we can get to, we will.
Yeah.
So a patient would go there for an assessment as well as
What usually happens is the GP would send us a referral, and we would contact the patient and CC the GP on any and all material or any and all findings that we have. The patient would be assessed by an interdisciplinary team of OTs, PTs, nurses, and dietitians, and we're there. It's a chronic disease management model. We would want to see the patient as early as possible and diagnose whether or not they had OA and whether or not they are appropriate for surgery or are conservative pathways.
Okay,
thank you very much. Does that answer your question?
Yes, absolutely. That's great.
So in just moving on there, thank you very much, everybody, for all that input in that. It really helps to inform everybody. So some of the things that we're looking at in just some of the key changes to clinical practice that we hope to see are a more robust and rapid diagnosis of especially the rheumatoid arthritis patients starting rheumatoid arthritis patients on the appropriate medications, which the rheumatologists say is not NSAIDs. They would like these patients with rheumatoid arthritis to get started on the DMARDs, which are a class of medications that are very much stronger than the anti-inflammatory medications such as naproxen or ibuprofen or aspirin or Tylenol. Certainly Tylenol as part of the pain can be used, but being able to monitor the rheumatoid arthritis and following along appropriately to know when the disease has become less active is critical. And finally, appropriate imaging and timely referral are critical around both the rheumatoid and osteoarthritis. In rheumatoid, as the referral as soon as possible is what the rheumatologist would request, and for osteo, referral when clinically appropriate is what is requested. So now in just looking at the specific tools, what we developed, and for both Jenny and for Manoj and the PSP people, you may be familiar in other modules you've done. Jenny, I think you said you'd done the mental health in the past, and you might remember the algorithm with the things that you could click on to be able to get at all the different tools. Manoj, if you haven't been involved with this before,
I have been, and I'm actually one of the GP champions for the child and youth mental health as well.
Oh, good. So you have that as well.
Yes,
so in other people who haven't seen these before, this isn't a guide to tell you what it should be done, but think of it more as a table of contents that's listed in a functional rather than traditional way of having page numbers, and you have to do searches around where things might exist through indexes and references as such. So people can use this in a structured way to be able to get at the different tools that are available. So if someone's presenting with a musculoskeletal complaint, that patient self-monitoring and management, and it should probably be looking at the red flags, are important as first criteria. And certainly when you're examining the patient, looking at the red flags for the rheumatoid arthritis, for osteoarthritis, are listed here. And I'm not going to go through all of them. They're just things to think about that you should might consider that it might be something other than osteoarthritis, and that there are some certain risk factors down at the bottom. If you want to go directly to the rheumatoid arthritis red flags by clicking on that, certainly clicking there brings the red flags up for the rheumatoid arthritis and the different things that you might consider that indicate that the inflamed joint that you're seeing is not rheumatoid arthritis but might be something else. And by clicking on return page 1, we can go back to where the red flags are with a little bit of a summary of the different things to consider in the red flag. As far as being able to separate going into inflammatory and non-inflammatory, those pieces that we had mentioned as the classic features, not necessarily specific, but some of the things to think about that were mentioned before, with joint heat and swelling and the morning stiffness for more than 30 minutes, swelling in more than one joint, and that the pain is increased with rest or immobility, are things that are suggestive, not absolute, but suggestive of inflammatory, and then the things that are suggestive of non-inflammatory. And then if you want to be able to get at all the general tools that we're talking about in here, including race referral, patient questionnaires, and differential diagnosis and opioid management, those tools are present down at the bottom in much like an index that you can get at. But specifically, if you're looking at either rheumatoid or osteoarthritis, by clicking on any one of those, it takes you to a basic flow of what our visit with a patient and our thought processes might go on. We're in the waiting room. There's a patient questionnaire that the patient might be filling out, and the MOA might give out to a patient if they know what the patient is coming in for. Specialists are always surprised to hear that in many cases, as family practitioners, we don't know what the patient is sitting in the room for, and we're just introducing ourselves to their problem for the very first time. And that's one of the things to ask as a question to the physicians as to whether or not the MOA is actually asking what the problem is at each visit. Trish, do you do that with Jenny's patients as a standard thing?
I just ask them what they're here for.
Yeah, ahead of time when they're making the appointment, do you actually ask them what they want the appointment for and actually write down the problem?
The receptionist usually puts it in the system.
Okay, so it is there as a workflow. You'd be surprised at the number of offices that don't use that as a workflow piece, that they make an appointment for the patient and don't ask the patient what they're coming in to see the doctor for. So the doctor is truly coming in to see the patient absolutely cold. And if that happens, it means that there's a lost opportunity to do things like Manoj probably has handed out PHQ-9s in the waiting room, or Jenny's done the same. You know, if you're Manoj, when you're doing the child and youth mental health, having either the child functional assessment or the teen functional assessment handed out that the child can fill out in the waiting room while they wait. Well, this patient questionnaire is the same idea, that it's something that can be handed out in the waiting room and filled in the waiting room or in the office while the patient is waiting for the physician to come in. One point, as with any of the tools in the algorithm, if you print by printing this button here, you will print all 103 pages on your printer. Please print using this button here, and it will print just the page that relates to what it is that you're interested in. And a question like this might come up and you just click yes and away you go to the default printer. So that's an important piece to remind people of. Use that, not that. Otherwise you have an unhappy staff where you've used up pages and pages and reams of paper. So we can return here to the rheumatoid arthritis page. There's suggestions in here about things that you might look at in the history of rheumatoid. This little diagram with the joint distribution that's typical in rheumatoid is helpful. There's another diagram that's a little bit further on that looks at the joint distribution in rheumatoid versus osteo versus psoriatic arthritis. It's just interesting and sometimes quite useful to help differentiate what kind of a problem you're dealing with in a patient. There's a suggested physical exam. There was a lot of discussion around using the a physical exam scale. It was the assessment of the disease activity. So using what's called the SDI or the CDI. Manoj, have you ever used that, or Jenny, in your assessments of patients?
This particular page?
We're on the slide, so it's hard to follow.
Ah, okay. On the slides, it's not there because I'm now on the algorithm, and I'm on page 31 of the algorithm if you have it. But Manoj, yeah, this particular page.
I haven't used this particular page, but I was going to ask you if you could email me or something the slides from today's presentation.
Yes, absolutely.
Yeah.
Yep.
Okay.
And I'll actually email you as well. You'll get an email of the algorithm as well. And Jenny, I'll make sure that you get that. And the PSP people, I believe that PSP Central will make sure that you get both the slides and the algorithm. Is that right? A promise there, Sarah?
Yes, I'm going to send the slides right now because I've got them, and the algorithm I will send when we receive it.
I'm also
Okay.
wondering if we could get thumb drives so that we could, or a thumb drive or what have you, so would be able to load it into all our network computers, or just through the email we'd be able to do that, I suppose.
The email wasn't that useful.
So Sarah, I'm just sending you this algorithm right now so that you have it.
Oh, fantastic. Thank you.
And that you can send it out to people right away so that they have it. So for those of you that can't see it, the S-die and the C-die are calculations that are made to assess what the disease activity is. The rheumatologists, many rheumatologists felt that this was a worthwhile piece of information for them to have. Some felt, and that I've dealt with when I've referred patients, that they don't use it. And it gives, much like the PHQ-9 would with depression, a single number that tells you what state the patient's at with their rheumatoid arthritis, whether they're in remission, and down at the bottom, if you have a S-die value of less than 3.3, low disease activity, moderate activity, or high disease activity, which would be a number that's greater than 26. And that's composed of the physician assessing the patient and saying, how active is this disease on a scale of 1 to 10 or 0 to 10, the patient giving an assessment, 0 to 10, of how active their disease is, and combining that calculation with the number of swollen joints. And in the case of the, and that would give you the total for the C-die. For the S-die, you add the value of the CRP, which is for the PSP people, it's just a calculation, it's a test result measuring C-reactive protein, which is a protein that it gets elevated in the case of more active inflammation. It's non-specific, but it is used to measure how much inflammation is going on in the body. And Manoj, have you ever seen that before?
No,
this
I don't
calculation?
Familiar with it. Not
Yep.
familiar with this one.
Yeah. Jenny, have you ever heard those terms before, C-die or S-die?
No, I haven't, but I have to tell you that there's nothing that refers to those numbers here in the slides that you sent me. Page 31 is an algorithm.
No, correct. No, it's not 30. Sorry, Jenny, it's not page 31 on the slides. It's page 31 on the algorithm, which I'm showing on the webinar. So I believe Sarah's going to try to send you the algorithm so that you can see it. And I think.
Can I just ask Jenny, what is your email address, and we'll send it right now. You're not on the invite list, so.
Oh, I'm not on my computer, and so my email address is Northern Health. So it's jenny.lee, L-E-E, at northernhealth.ca.
But it won't help you now, but we will send it to you later.
Okay, thank you.
So it's a bit tough, and I apologize, Jenny, and for your group there, with Trish as well, in that you can't see the slides of the algorithm and be able to see me jumping around on the algorithm, but it works very much like the mental health algorithm. And it is interesting that, as both of you mentioned, both of you being familiar in this area and have worked in this area, that neither of you use the S-die or the C-die. And that certainly was something that we're looking at as an evaluation of this tool as to whether or not there's relevance to it in being able to assess the disease activity in someone with rheumatoid arthritis for us as family practitioners.
I find, Bruce, at a practical level, most of the rheumatologists don't do much work in pain other than inflammatory. They want to see inflammatory conditions, but not much of the other conditions. So if there's any kind of inflammatory condition, they're real excited. They want to see them right away. But everything else is kind of, you know, the Journal of Rheumatology, Canadian Journal of Rheumatology, has even listed that a lot of the pain conditions are best addressed by the primary care physicians, because the rheumatologists don't do much with mental health and with sleep and with these sorts of things that are so interactive. There's a rheumatologist from Toronto who's come out. I was asked to wanted me to come and attend some of his things, because he's one of the few rheumatologists in the country who actually has an interest in the stuff most of the other ones don't want to do. But when it's inflammatory, locally anyways and anecdotally, I mean, our guys just want to see them right away. The other stuff can be really a long time. They really don't want to see them even.
Yep. Do you find the same, Jenny?
Well, my rheumatologist does see patients with fibromyalgia, but when it comes to prescribing opioids, she sends her patients back to me.
You're fading a little bit, Jenny.
So my rheumatologist is actually interested in fibromyalgia, but when it comes to prescribing opioids, she sends all of those patients back to me for the opioids. So.
Yep.
That's a tough position to be in.
Yes. Yeah. Yeah. I agree with that, and certainly that's one of the reasons we included in the Train the Trainer one a brief section that Brenda Lau presented on opioids, and she's a pain specialist down in Vancouver that was well worthwhile in there. So again, I apologize, Jenny, that you can't see me jumping around in the algorithm, and when I make reference to certain things, it's not on the slide deck, it's on the algorithm, but we will return the slide deck and I'll tell you which page we're on quite soon, okay?
Okay.
Sorry. So again, there's a page that you can look at for differential diagnoses for both inflammatory and non-inflammatory, and look at there's a link to the GPAC guidelines and suggested investigations for rheumatoid arthritis. So one of the things that I've done in my EMR is that I have preset lab tests and preset imaging that I just have to click on, and it already has all the different investigations that I should be doing with somebody that I'm investigating first time for rheumatoid arthritis. So looking at C-reactive protein, complete blood count, renal and liver function and enzymes, and then reminders about the x-rays. So certainly in rheumatoid arthritis, doing yearly x-rays of the hand and feet is what's recommended, as well as any of the active joints that one is interested in. And beyond that, looking, I'm now clicking on a link that takes you to management considerations and talks about early management in rheumatoid arthritis, including patient education, referring to physiotherapy, and starting on some medications to consider to start on an initiation with the DMARDs. In this recommendation, they're recommending starting either on hydroxychloroquine or sulfasalazine. In a couple of patients, I've started them on sulfasalazine, and once the rheumatologists get them, they're quite often very quick to switch them over to methotrexate. And there was a bit of a discussion about that in the group about whether or not the family physicians could or should just start on methotrexate. And the general consensus from the rheumatologists was that starting on one of these two medications would be preferable to starting on methotrexate for the family physician. Now for Jenny, that may be a little different with you, and Manoj with you, since that you've had more experience in dealing with methotrexate and being sure of the diagnoses, but that was their recommendation. And one of the other things that was sort of a little pearl was when patients had quite severe symptoms, one of the things that was suggested was rather than, and it's say a specific joint or group of joints, doing an intramuscular injection of 40 milligrams of depemedrol. And that gave some fairly quick, possibly only temporary relief just to get somebody achieve a little bit of peace of mind. It's certainly one thing I find with patients is that even if you can give them a short period of time where they have relief, that is just so so much appreciated, rather than just having the knowledge that they're going to deal with chronic unending pain. Manoj, would you agree that sometimes those brief respites are really helpful?
You're talking about for injecting of depemedrol?
Well, for any pain, you know, if someone can have just those brief periods of respite, and in this case specifically the injection of depemedrol to just lower the disease activity down.
I would say that's probably a reasonable thing, sure.
Yeah. And so those are just other management considerations, and they talk here about just a reminder of both in early and established rheumatoid arthritis and some suggestions there. Monitoring and follow-up, of course, with each of the different DMARD medications, there's a different set of recommendations. What I've done in my electronic medical record is that if I'm prescribing something, it shows me right on the page for that DMARD as a template what the recommended follow-up are and what lab tests I should be ordering for that specific DMARD. So each DMARD has a different set of recommendations as to how to follow it. And on the link to the page with the monitoring and follow-up is a link that will take you to the self-management and brief action planning and goal setting. I won't go there right yet. And then finally, when we should refer to rheumatology. And Jenny, for you that you can't see, there is a link here to the Raceline page that has all the information about the Raceline, and it lists which specialties you can refer to if you live in Vancouver coastal catchment area, which specialties if you're Vancouver coastal and Fraser Health, and which specialties are available for people provincially. So Raceline, in this case, they list is available provincially for patients with child and adolescent psychiatric problems, patients with chronic pain problems, and patients with treatment-resistant psychosis. So those are the three things that are in there, Jenny, that might be relevant for you being more Northern Health. And you're right, Manoj, in this, there is no mention of the orthopedic surgeons, but for Vancouver Coastal and Fraser Health, the Raceline is available for the rheumatologists. And then there's some resources for physicians that are listed in some of the pages, and some self-management information and some links to self-help management as well.
With the orthopedic surgeons, once again, local orthopedic surgeons are on good relations that we can contact, but yeah, it's not formalized.
That's right, correct. And when we're looking back at the very first page with osteoarthritis, it has a very similar, when you click on the link, it has a very similar flow through the very same patient questionnaire, some history items, physical exam items, management options, medications, guidelines. It's all set up in the same way and using an overlap of tools from rheumatoid arthritis in osteoarthritis. And I won't go through them completely as well. As well in this whole algorithm and Adobe PDF file. There's links to directly from the front page, as mentioned, to patient self-management, the PHQ-9 assessment form, and because these conditions are chronic diseases, it is very important to monitor on some kind of ongoing basis the PHQ-9 and look at anxiety as well with the GAD-7, as you had mentioned, Manoj. And there is an opioid management section that utilizes the opioid manager. Manoj or Jenny, have you seen this two-page opioid manager before that is a complete set of recommendations around opioids, including initiation, the opioid risk tool, the initiation trial, maintenance and monitoring, aberrant drug-related behavior, and also equianalgesic table?
Are you
I've
talking
seen similar.
about the McMaster opioid manager?
Pardon me?
Are you talking about McMaster's opioid manager?
Correct.
Yes.
Yep. And Manoj, you've got similar tools as well.
Yes.
Yeah. So the opioid manager for the PSP people is certainly something that the college has been increasingly interested in, and there is a ton of, to sometimes the family physician's eye, contradictory information, evidence, and studies that come out on just how we as family physicians should deal with patients with chronic non-cancer pain, and it is a challenge to all of us as to, with any one patient, what's the best approach. Manoj, do you have any sort of insights or comments just in general about what you see, especially if people had referred to you
Well, no,
with your clinic?
I don't do a referral-based practice anymore. I'm a primary care doctor, but we do a lot of these sorts of things. That was in the past. But
yep.
With the issue of pain and chronic non-cancer pain, as you may, there was a large pendulum swing one way years ago where the national colleges were saying, doctors, you're not taking pain seriously. You should be addressing it better. You should be prescribing opioids, long-acting opioids. And then, of course, there was a larger amount of addiction that came about, and some deaths and overdoses and so on. And the pendulum has swung, of course, the other way. That, you know, to be very, and of course, the data suggests that there is an increased amount of death with prescription opioids and mixing with alcohol and things like that. And we should be a little bit careful, well, very careful. But the pendulum certainly has swung the other way. So there's been a change with the college's outlook. It is a very difficult area because there is overlap and there's comorbid conditions, and it's a very difficult and challenging area. So I mean, to be frank, many times I try to steer away from opioids if it can be helped, or certainly, you know, not. It's very don't prescribe a lot of opioids nowadays. But then again, the pain population I'm seeing may be a little bit more complex than strictly osteoarthritic pain. But yeah, it's a challenging area. I would agree. You probably have a few stories yourself about the issue of opioids and all the sort of things that can come about, that can come up.
Yeah. Elizabeth, I hadn't brought you into this conversation. Have you had much dealing with opioids and pain in your practice?
Well, at this time, nurse practitioners can't prescribe opioids, but I recently attended the Pain and Suffering Symposium and reviewed these documents because the legislation is changing and we will be prescribing them shortly.
Right.
So presently, for my patients that require opioids, the prescribing is done in consultation with a physician colleague.
Yeah. And, you know, certainly, and Jenny, you can probably concur since you've been in practice, you said, for a while, We got caught up in this, as Manoj said, in the 90s with increased prescription of opioids, and we often, as family physicians, will get patients either referred to us or that we take on, and you get many physicians that start up in practices that they've taken over from older physicians who they then now have to deal with patients that are on large doses of opioids that are very difficult to manage, and it is a very tricky and difficult area. An area that many physicians would wish didn't exist, but recognize is very important to their patients. Sharon just asked a question about whether or not the opioid manager is used as a contact point with patients.
More of a contract with the client?
I can't
really read it, it's so small, but...
Yep. In the pain module, and the reason that I'm not going into too much detail on the opioids or touching on it too much, and I'm just scrolling through here so you can see things in a bit more detail. In the pain module, we'll be dealing, that the PSP is going to have out in December. We'll be dealing a little bit more with the actual contracts, and there's some recommendations. In this slide set that was presented at the train-the-trainer session, there are some examples of the things that should be contained in a contract. That's a separate slide that isn't included in this slide set. But it's certainly something that's important, that's recommended, as well as monitoring random urine drug screening, a stepped approach to opioid selection. I don't know if anybody has been involved with before, or whether in Northern Health they have exist, but Manoj, you may be involved. The pharmaceutical academic detailing people have just done a study going through all the studies, looking at all the recommendations, and putting together a module that they are putting out to physicians. And they are working in conjunction with the pain module that PSP is doing, that is to do with opioid use in chronic non-cancer pain. And there's some very interesting looks at some of the assumptions that have been made around pain and opioids and medication. So by no means is there an absolute definitive answer or tool that is the absolute definitive right way in dealing with people with this kind of pain and or with opioids. Suffice to say that this is just some place that people can start and have a tool available to them that puts everything that is relevant to people that are needing a quick look, having everything in one place, and making sure that they're looking at certain items. So that's what that does in there. Yes?
But I would also think that if you were to use that opioid manager when the client is with you, that you would be able to engage the client in managing their use of the opioid, because they'd understand right from the beginning the risks of being managed that way.
That's very true. Very good points in there, and certainly recommending that you're working on functional goals, as up in the top is goals decided with patient. I guess part of this is that, such as things with the goals, it's a reminder, it's not a directive on exactly a script on how to do that. So that opioid manager it's a good reference tool, a good reminder. Your suggestion is well taken and may be appropriate for some people and may not work well for others. So I'm just going to close the algorithm if no one has any other questions about that. Were there any other questions in the algorithm for that I just went through? Sorry, go ahead. Yes?
My only question is, you are going to send this to us?
Yes.
So that people have access to, because it looks like an excellent tool
Yes, we will definitely send it to you as part of the slide set, and you'll have this to be able to use. And
Okay.
Sarah will make sure that everybody gets it, as long as she has all your emails. So make sure that anybody that wants this, let Sarah know about that email.
I have already sent it to the practice support coaches and to Manoj and Jenny and Elizabeth. Is there anybody else actually right now that can just tell me that I've missed?
Well, it's Sharon here, and I have never seen it.
Okay, thank you.
Maybe I just didn't see it, but I'm looking under all the things practice support program sent me, and I don't see anything like that.
Are you on the listserv, the coordinator listserv?
Yes?
Then you should have it.
That's fine. I'll send it
Yeah.
to you, Sharon. Anybody
Yeah.
else?
Thank you.
Okay, thanks. Sorry, Bruce.
Not a problem. So I'm just closing that down right now, and I'm going back to the slide deck, slide number 22, Jenny, and Lee. I guess you're the two people that aren't following along live. So it's actually the slide deck shows a picture that's slightly slanted with the algorithm on it. Okay, slide 22. And that, in a nutshell, and I recognize that we've gone through in just over an hour and a half everything that was covered in 3/4 of a day at the Train the Trainer session. Fortunately for Manoj and for Jenny, you're quite familiar with this material anyway, so I'm hoping that none of it is too surprising to you. What would be really appreciated in the time between now and when the Train the Trainer 2 is that you can take a look at the tools and the resources and be able to make some kind of an informed comment as to how practical these things are, how relevant they are in practice. None of these tools are written in stone. They are just suggestions, recommendations, a lot of trial and error, and now we're moving them out to other users to see what their feedback is on them. So we appreciate anything more that you have to add to that. Did anybody have any other questions on rheumatoid arthritis or osteoarthritis compressed into a very short timeline? I apologize. That we might be able to answer now, or that might be relevant right now. That's a good sign that there's silence. So we're going to move on to just talking about low back pain. I think, and again, Manoj and Elizabeth and Jenny, you can argue one way or another, but again, as I said, low back pain seems to have most physicians have an approach to low back pain. And what I think that we're trying to do is not so much to tell them how they should deal with low back pain, but try to give them some tools and resources, and perhaps, especially when Hamilton Hall is speaking, how to deal with patients with area-specific types of low back pain, and to give them some guidance in that area. So, in the things that came out with low back pain is that we're really dealing with 3 different conditions that are split on timelines. One is dealing with a patient that has low back pain, which is defined as pain that's been present for up to 4 to 6 weeks. And the important areas in there are the screening for any other conditions that might be alarming. Very importantly, looking at yellow flags. And yellow flags are those beliefs and those situations that are affecting the patient's psychosocial and work life, and seeing how pain might affect them. An emphasis on that and Manoj, you've mentioned this before, no imaging unless there are some specific red flags that have come up, and that education, exercise, and activity prescription are very important. Reassurance, making sure that people, their fears are dealt with, and making sure that their pain is controlled in an appropriate way. And these were based on guidelines from the Alberta and American College, as well as some New Zealand guidelines that came out that was very evidence-based. And there is just a sort of a flow sheet around low back pain that's showing on this slide, slide 25, and some discussion about low back pain. That's a patient handout on slide 26 that you can print out when I show you the algorithm, and this is just part of the handout. Again, to emphasize those points that we're making about low back pain at the beginning. And the key messages for the provider are that when the pain, or if the pain is going beyond 6 weeks, then it's important to consider other treatment and or investigation referral for the patient, making sure in the beginning that there's no red flags when you're dealing with a patient. Anybody have any questions on just acute low back pain? I think that's a common condition, and for most physicians, they're fairly comfortable with that. They may not have the tools to suggest to patients on what specific things that they can do, but certainly sending the message and providing some handouts that emphasize movement and emphasize that there's nothing serious going on are quite critical. Subacute low back pain is defined slightly differently and is a time period beyond the low back pain, and there's just an example in here of a patient with subacute back pain. It's defined as pain that existed for 6 to 12 weeks, and the thing here is to start thinking about what else might be going on, and to make sure that the physicians have reevaluated the situation and haven't got caught just following the course of seeing the patient, giving them some medications, and sending them on their way. That especially yellow flags and red flags need to be reevaluated. And sometimes it's appropriate to consider short-acting opioid management. And the pain specialists speak of short-acting as being 30 days, up to, in some cases, perhaps 3 months. But 30 days is certainly the time period that they're suggesting that can be tested. And if the opioids aren't working in 30 days, then escalating their use and increasing them is not going to be effective. Manoj, more comments about that or support around that? It's a big topic, and it's going to be dealt with somewhere else.
You hate to be too general and over
exactly
area, but it's there's one approach is yeah, of course you don't want to miss stenosis or some pathology. In general, Dr. Hall, in one of he's written a whole bunch of books, but in one of his series, and this is where Dr. Ferrari, the rheumatologist, who's expanded on Dr. Hall's work, and this is a tool that I use that I hand out to patients. There's actually type 1, 2, 3, 4, and mixed low back pains. And you can kind of get a sense for flexion and extension if there's a type 1 or type 2 or mixed. And you can actually predict the time period of how long the duration would be. So type 1 can be up to weeks to months, and type 2, which with extension, is usually days to weeks. So if you can give some kind of a prediction and that comes true, then that can help with actually a diagnosis more so of low back pain. And I find that's a good tool to have an education and discussion around what to expect. But yeah, you definitely don't want to miss something that's pathological.
And I think this is what's going to be really valuable about Hamilton Hall speaking to us at the next Train the Trainer, is that those very specific types of expectations and actions that can be taken with certain types of patterns are what really will be appreciated by the physicians. What do I do with this patient is going to be very, very helpful. So we're really looking forward to that. Again, you know, for subacute low back pain, there's a flow sheet that you can go through when you're looking at different things, and it's available in there. And medications, and on slide 32, looking at the level of evidence and summary grades for the benefit or non-benefit of certain kinds of interventions, including all the different medications, exercise therapy, biofeedback, laser, diathermy, all the different kinds of things that are out there in the world. And it's quite valuable to be able to use with patients when they're coming to you and saying, you know, I'm going to have this kind of therapy done. What do you think about it? We get asked that question a lot. Or why, you know, I went to this guy and it didn't work. How come? Because it worked for my neighbor. Well, you can refer them to this appendix that helps show some of the evidence behind some of the different kinds of therapy, which is very interesting to see.
It happened to include marijuana.
Yeah. You know what? When that came up even in the pain module for discussion, boy, everybody just, it was like cockroaches running for the corners. Everybody scuttled away from that one like it was crazy. And the pain specialists would prefer not to go there in that discussion. It's a really good point. It's one that all the family physicians asked. As far as what the evidence shows, the pain specialists have a tough time being able to support that. However, they're not willing to come out against it passionately. It's just an interesting reaction to see. I hope, Lisa, that with the pain thing, the pain module, when it comes out with the first Train the Trainer, that there is a little bit of time for discussion on that. And we've discussed it a couple times about whether or not there should be. But no, it's not mentioned in here, and very pointedly, purposefully.
But we
which
do
doesn't
have
help.
a whole hour set aside for the case study clinical discussion in small breakout sessions. So.
Yep. So that might be something to come up.
Yeah.
And certainly, again, the key messages, and one thing that Manoj alluded to, most episodes of back pain will improve. Certain types of pain quicker than others. And one piece to really emphasize with patients, and whether they listen or not is challenging, but that once you've had low back pain, recurrence is quite common to within 12 months. And so it's really important, you know, to get through the episode by being active, and then to try to encourage them with brief action planning and self-management to try to break this cycle of recurring back pain and recurring disability because of that. And then finally, a bit more difficult is the persistent and recurrent low back pain, which is going on by definition. The subacute ended at about 12 weeks, and so from 3 months onward, low back pain, persistent pain. However, you know, that sort of guideline and milestones on the date that I gave you are flexible, and so certainly some people could be considered to be, you have a pretty good idea that they're going to be chronic, persistent low back pain because the type of pain they have and the way they're presenting suggests that, you know, even at as early as 8 weeks, it's going to be a long-term problem. And again, looking at the guidelines, education and exercise are just keystones of trying to take care of back pain. However, when it becomes chronic, more and more, as with other chronic diseases, the psychological issues with depression and anxiety creep in, and certainly the psychosocial issues around work and self-worth and value to themselves and society creeps in. So again, pain is an issue in the chronic pain, and how you're going to deal with it. I have a handout that's part of my pain and low back pain template on my EMR that tells people how to use acetaminophen and to use it effectively. And the recommendation is to take up to 4 grams per day, 3 grams in some people, and how to take it. So taking acetaminophen, the extra strength version, 2 500 milligram tablets, either 3 times daily or 4 times daily as appropriate, and then using anti-inflammatories where appropriate as an adjuvant to that. Muscle relaxants, and then finally short-acting opioids. The biggest things with patients is reassuring them that you're not just ignoring them, their pain, that you're acknowledging that they have pain, that they can work through it, and that you will deal with it and help them through there. Manoj or Jenny, do you have anything else there that you add with how you might deal with people with that more chronic pain from musculoskeletal issues?
I have a patient I'm even following weekly who he had a depression a couple of years ago, and he's developed a chronic low back pain, where he was admitted actually to, I think he showed up at the emergency room when it was acute in the fall of 2012, and we've investigated. I mean, this is a patient, of course, that we'd want to investigate more. So MRI and imaging and so on had not shown any kind of pathology, but he has this consistent back pain. He's now back to work, but I still meet with him weekly around. He has had some benefit from. Of course, there's other medicines that can be used, inclusive of Cymbalta, one of the SNRIs. Now you're getting into more of the neuropathic sort of pain algorithms and chronic pain medicines. But it still hasn't been 100% effective, so I still kind of have a weekly, almost coaching interaction that he finds beneficial, so I don't mind doing it. And it's gotten him back to work at some levels, where they've given him an ergonomic station where he can sit and stand, and so he's somewhat functioning despite this chronic back pain, of which there's no known pathology. That's the one that comes to mind.
Yeah, and I have similar patients to that I do the same type of things with for precisely those same reasons, in that it's keeping my patients functional. And I think you're hitting on the key point there, is that we want to keep these people functional no matter what we do, keep them safe and functional. Jenny, what about you? Do you have any feelings around how you're dealing with people with that chronic low back pain and dealing with their pain?
Dr. Lee just had to step out for a few moments. You missed
okay.
By about 40 seconds. But yeah,
okay.
She did have something to add, but she's had to.
Trish, can you pipe up when she comes back in, and we'll get her. I'll come back to that that comment or that question. Thank you. So when you're talking about low back pain, again, there's guidelines for that about conservative treatment and pharmacological treatment, and even getting to more invasive treatments with recommendations around surgery, and again, I should emphasize surgery when there are no red flags and no indications for surgical intervention from early on. Certainly, again, as what Manoj was speaking to, not just the opioids, but there's other classes of medications, and this just touches on them here very quickly, such as the tricyclics, and then there's other classes of medication beyond that can be used in dealing with chronic pain, sometimes depending on whether it's nerve pain or more musculoskeletal pain. and a handout for patients with chronic low back pain to help reassure them. And again, this handout is in the algorithm that I'll show you in a second. And talking about things that can do at work. This is just to remind about work modifications. I think one of the most challenging pieces that I find in low back pain is actually working with the employer. WorkSafe BC is trying to develop a program to help educate physicians around working with employers in modifying their work activity, ways of communicating with employers, and when to communicate with employers. So that's certainly going to be helpful to us as well. And a little bit of information on how to fill out forms. So that'll be quite interesting in dealing with all the insurance forms that we sometimes have to fill out with people with not just chronic low back pain, but chronic pain in any form. Again, key messages with the chronic low back pain. And certainly for patients, I see a lot of patients with chronic back pain that become very dependent upon either some kind of hands-on therapy, and so become, and I don't mean the word in a negative sense, but addicted to things like massage therapy or physiotherapy, which in themselves may not be bad. However, it's the patient's attitude towards somebody else being responsible for their care that is much like people being responsible for being dependent upon opioids that can become a problem in itself. And the main thing around all this is try to reduce the fear and anxiety and really emphasize active self-management. So what, in summary, again, before I show the algorithm for low back pain, what we're working on is that there's really consistent messaging around getting people to be active, limiting the amount of imaging and investigations, and that's been referred to a couple times, that we don't need to do a low back x-ray at the first sign that someone comes in when there's no red flags. That MRIs are not needed with every person that comes in with back pain, and even possibly pain that radiates down the leg, unless there's some other active indications for that to be done. And that self-management and focused treatment are very critical. Before I go off that, is Jenny back there, Trish?
No, she's not.
Okay, no problem. So finally, into the algorithm on low back pain. And just, Trish, for your sake, I'm off of the slide deck right now and showing the algorithm for low back pain. It's a little bit busier than the osteoarthritis and rheumatoid arthritis joint exam, but it has a similar kind of structure to it, in that there's self-monitoring and management, clinical presentation, and looking at red flags. And when you click on the red flags, it takes you to the page of the things that you need to be aware of and watch for in low back pain that might indicate that there's something more serious going on. And certainly the specialist kept emphasizing the first one, which is called Cauda-Equina syndrome, where there's an association with loss of bladder and bowel control and numbness around the area of the bum and underneath the groin and the saddle area that's all numb. And that's an emergency if that happens. And some other items that are urgent in there as well. Sorry, Manoj, yes?
Yeah, I'm sorry, another question that's commonly asked with back pain in this office with the Cauda-Equina syndrome is also lack of erections as well as bladder bowel control. It's almost like the three things to ask at once.
Correct. Yeah. Thank you very much. Actually, that's something. Thank you. You know, there's a good point there that I will add that to this. I'm going to make a note that I'm going to add that to the red flags in there. So thanks for mentioning that, because that's a question I asked too. Okay. So anyway, I won't go through all the different features again. Again, referring back to low back pain and look at that piece that Manoj had mentioned before, is that, you know, there's, in this one it's mentioned as morning stiffness for greater than 1 hour. And Lisa, that is a reminder that we need to, I believe this came up, that we have to change that to 30 minutes in there, because it was a point that came up before from this.
Yeah. Yeah.
So that's just a reminder to me. And again, if that you want to print that out, a reminder to print it, you click on the little icon at the top rather than clicking on the icon that is over to the side, because if you click on the side icon, it'll print out 87 pages, whereas if you click on the icon at the top of the page, it'll just print out the red flag pages. And you can return to page 1. There's a handout that's you can able to give to the patient, talking about encouraging them to be active and reminding them that they've been looked at, and from their history and physical there's nothing serious going on that they need to be concerned about. There's a patient questionnaire that's exactly like the rheumatoid arthritis and osteoarthritis that can be given out in the waiting room. And there's history and physical differential diagnosis and so on, including referral options with the race referral connection in there. There's also a little section in there for referral criteria that the specialists agreed were criteria to help the family physician in deciding whether a patient should be referred to a spinal surgeon or not. And so couple of points in there that were, I think, quite relevant that could be used as training points with physicians in being able to help them determine that. On the side are some very specific tools that can be used in looking at the pain, such as the dermatome map. So depending on if a nerve is being compressed at one level or not, it shows what parts of the arms or legs that might refer to as the level of where the nerve is being compressed in the spine. And a set of questions around neuropathic pain. And so that's again to determine whether or not there's a likelihood that the pain that we're dealing with is related to a nerve or might be more musculoskeletal. And that's a questionnaire that can help a physician determine that. The opioid manager is in this algorithm as well, exactly the same opioid manager as we previously discussed. And this also includes a tool that's going to be used in the pain module, which is the brief pain inventory. And Manoj, there was a lot of discussion around what tool was going to be used as an initial assessment and an ongoing assessment that would provide evidence-based analysis of how a patient is doing with their pain, so that there is some kind of comparator from one visit to the next. And this was the agreed tool that would be used.
Tool about 10 times a week.
Yep.
Yeah.
So
this is not unusual. And it's a great indicator. I mean, because of course as a family doctor you're time pressured. We do have chronic disease nurses, but I mean this is something patients can do on their own time or in your office or what have you. And it's a good, at least it's a communication tool where a picture says 1,000 words in terms of where it's located, the nature of the pain, how it's affecting other things like sleep and functioning and mood and so on. So it's a very good tool.
Yeah, and it's quite informative. You know, I've used it with my patients, and when they draw out where their pain is, boy, that's really helpful whether you're using Hamilton Hall's pattern recognition or whether you're looking at something to determine whether you've got a musculoskeletal problem versus a nerve problem. So it's amazing how accurately patients can draw that. So, sorry, Manoj, go ahead.
I'm sorry. They can draw all over their body as well. So if there's different pain things, it can bring out other diagnoses as well.
Exactly, exactly. So what the pain specialists were recommending that the brief pain inventory questions 1 through 8 are the ones that you would definitely use in your initial assessment of somebody with low back pain, or in fact any pain, and that if you were following a patient along to see the progression of the pain, either for improvement or whether things were falling apart, that question 9 with its 7 questions was what they would hope that family physicians would use, so that the whole set of 9 questions wouldn't necessarily have to be used with each visit, each subsequent visit with a patient. I don't know if you do it that way, Manoj, or not, but it was a bit of a compromise.
In fact, there's a third page that you don't have here in terms of it's a summary of, I don't know if you have another page to this? There's a
no.
Page, no, you don't. There's a third page that actually lists, I'll just open this in our system here. The third page lists the diagnoses. I'll open it to okay, so it would be the primary pain diagnosis. Then there's other relevant diagnoses. For instance, renal compromise, restless legs, insomnia, sleep apnea, diabetes. Number 3 is current psychiatric status, so depression, anxiety, PTSD, ADHD, adult ADHD, other psychological factors, catastrophizing, chemical copper, dementia, fear of harm, challenging personality. Number 5 is psychosocial factors, type of work, support system, extended health plan, other stressors. Number 6 is overall risk assessment for treatment with opioids, which would be low, moderate, or high. Urine drug testing, PharmaNet profile reviewed. Number 7 is functional assessment. So you've scored them, the brief pain inventory, out of 70. So there's a slot where you can actually put the score. Then there's goals. They've listed 3 that you might want to record. Current medication, suggested treatment planning. That would be page 3 that's not there.
Okay. I'd be really interested in seeing that. And you know, I have never seen that specific one. There was another tool that was called the Pain Disability Index that they were looking at, but it was felt to be just a little too long. The concern was, would family physicians use this 2-pager with every visit? And there was some mixed support for doing the whole thing versus the small version for follow-up visits.
It's a lot to ask for every visit to do those 2
exactly.
pages. But there's a briefer one that you know, but then you have to know why you're doing it and when.
Exactly.
Yeah.
Yeah. And the briefer one was, I believe you're referring to the Pain Disability Index. But anyway, that's it's there, and just for people to be aware of it. And pain inventory, bunch of patient handouts, things that you can click and go to. Any of those links that the finger is pointing on mean that you can link to a handout. Again, a work recovery letter, just a suggested letter as a template for people to use for communicating with the employer about return to work and what's going on. And finally, some a bit of brief information about the length of time that drugs can be detected in the urine if you're dealing with somebody that's on opioid medications that you're monitoring urine drug screening. So again, the one thing I haven't touched on here is yellow flags, but and I will in a second. This all covers all those different areas that you might see through acute to subacute and chronic pain, and the different things that you can do in linking to resources, medications, and exercises. And hopefully is going to be expanded on when Hamilton Hall comes and speaks with us.
Just a comment, you flashed the urine drug screens. The hydromorphone needs to be, you have to write specifically about for that to be tested, because I think they need to use a specific technology, like a mass spectrometry or so on.
Yep.
Otherwise it show negative, but it could still be there.
Exactly. Yep. And The yellow flags is the really interesting one in this. I find this as just a tool is a bit challenging to use. When looking at it, it gives me some ideas, but as a practical tool, not so useful. And so we were able to come up with a number of questions that actually dealt with the pain, and to ask the patients that are built around these comments down here on page 37. And certainly, sometimes it's not necessary to ask these questions. It's more important that the physician is just aware to keep them in mind when he's dealing with that patient, because many physicians know how the patient believes the pain affects them and can answer these questions without having to ask the patient specifically. But certainly asking patients about how they feel about work and whether or not they like their job and what kind of work they do, if it's shift work and whether it's heavy work. These things are all associated with yellow flags that should be noted. And some ideas on just sort of supporting people when the yellow flag does come up. Some just specific steps on how to manage the low back pain problems when the yellow flags are raised. So that is the algorithm for low back pain and the way to move around in it. Were there any questions specifically about that and about the tools and about how I moved through the algorithm and linked to different things from anybody? So that's a good sign as well.
Dr. Hobson, we have Dr. Lee is back in the room. This is Lee.
Hi. Jenny, one of the things that came up as just a question, and Manoj had spoken to it, and you as well, in dealing with patients with chronic low back pain, what you find are some of the issues that you have to deal with that are pain specific, and how you're managing them.
You know, here there's a big market for prescription drugs. So one of the big questions I ask myself is it a correct diagnosis, or are these people just coming so they can get narcotics to sell them?
And besides asking, so are you using any tools for that, or do you have any way other than going by your intuition?
Some of my MOAs know the community quite well, so they'll come in and tell me if someone's selling their prescriptions. I'm one of the few doctors here that uses urine drug screens. So, and I've talked about my concerns with patients who come up negative for opioids when I expect them to come back positive, and also about having illicit drugs in their urine when those come back positive too. I've had to stop prescribing to a bunch of people because of what I found.
Right. And I think that's one of the things that the pain specialists will emphasize over and over again, is that you would be absolutely surprised at who will come back with negatives and positives that you don't expect. And one pain specialist gives the example of a 74-year-old grandmother with chronic pain that he'd prescribed opioids to and did a urine screen test on and was negative. There was no opioids in her urine, and she was buying the opioids or getting the opioid prescriptions to give to her grandson, who was pushing her for them. So you just can't begin to predict. And And I think, Jenny, you made a really good point that you have to have some quite robust tools in your armory to be able to, and that's, I don't want to make it sound like it's an adversarial kind of system, but certainly the potential for abuse and misuse exists, and that we have to be aware of it. So thank you for that. Jenny, there's just a point on slide 47 that we went through the algorithm for low back pain that contained all the tools. Again, that's quite valuable there, and it has a and one that you may make use of in the opioid management is the opioid risk tool, to be able to look at patients and ask them questions about what their risk of potential misuse of opioids is.
So I use that quite frequently.
Good. Yes. So that's in the tools as well. And on slide 48, just, again, general pain management, that overall goal is looking at decreased pain, certainly improving functional status. We've had a number of patients that I've been in practice for 31 years, and my partner that had been with me up until about 6 years ago had been in practice for 5 years longer than I. And many times we had a locum in who was a person that was a GP anesthetist who dealt with a lot of pain issues, and through one thing or another, we ended up having a lot of patients that were on fairly high doses of opioids that in the last number of years since my partner retired, the person that took over from his practice and the people that I was dealing with, and since we don't have that locum anymore, we're having to work on getting reducing the amount of opioids that some people are taking, because they're certainly at levels that are at risk. And the incredible thing that you're dealing with when you're starting to have that conversation with people that are on long-term opioids is to do with their fear that you're actually going to cut them off of their opioids, not deal with their pain, and not have any other strategies for them. And it's incredible how much fear there is. And it manifests itself in many ways, from people that have been yelling and screaming at me to patients that have left my practice to patients that have been crying in the office. It's difficult. It's really challenging, and it really is important to have a really good strategy in dealing with that. And I'm sure Manoj and Jenny, you've seen it and you've dealt with it, and it's not an easy thing sometimes. Just some universal precautions about opioids, and we talked about those, and that's emphasized in this module. You're all aware of them. The opioid risk tool, Jenny, you're using that. Manoj, I'm sure you've been familiar with this as well. Yeah. And in here is just not actually giving people a specific word-by-word treatment agreement, but just outlining what the content should be in an agreement, treatment agreement that you may create. I've got several examples of treatment agreements that can be used as templates. I like this in that it just sets out some points to say what should be in a treatment agreement. I think one thing that's missed in here that should be emphasized is that I think as much as that there's expectations on the patient, there should be expectations for the physician as well. We have physicians who have patients that need prescription renewals that have gone on vacation, don't have locums, don't have any coverage, and have no plan for their patient to pick up their opioids. And that's an expectation, I think, that should be clearly defined with patients, that we have a responsibility when we have them on these medications as much as they have a responsibility to us. The opioid manager, again, that we've mentioned several times, and talking about function. what's important with patients in pain is that we focus on their ability to function rather than their ability to, than their degree of pain. Reassuring people that no matter what we give them for pain as far as a medication, an expectation, and some places say 30%, some places use the scale from 0 to 10 of a decrease of 2 to 3 points on the scale, but that we're not going to get rid of pain. We're just going to be able to decrease pain so that they can increase their function, and that we have specific goals to be able to show the patient for that. Manoj, again, you know, the brief pain inventory, and I'd love to see that page 3. And some in the opioid monitor are some predictors of aberrant behavior and some steps to move through pain. I'm going to skip through most of the pain things here because I think it's not something that we need to go through any further in there. You're quite comfortable with it. But to just briefly touch, and the last bit before there's some questions on patient self-management. Jenny or Manoj, have either of you been or seen any of Connie Davis and her group with the brief action planning?
No.
No.
No? How many of the PSP people out there have used brief action planning or seen physicians using brief action planning in anything that they're doing?
Denise, did you want to speak to that?
Yeah, this is something that's very new for the coaches that are on the call, Bruce, and they will actually be taking the brief action planning training in October, so this is new for them.
Beautiful, beautiful. It's the brief action planning is in everything that I've done with PSP is probably one of the most interesting and useful things as a tool that I've used ever in working with patients in anything. And it's not just in pain and not just specific to osteoarthritis, rheumatoid arthritis, or low back pain, but is really working on that self-management concept and working towards achieving some goals in a very structured way that is centered on what the patient's needs and wants are, not based on what the physician's needs and wants are. So, for example, the way that I might use this is that today I had somebody that I did a full exam on, and because they were quite overweight and their blood pressure I found was quite high, and I was quite concerned about this. And so I had pointed out to them some of the things that I found on the exam and from their history that were concerning to me. And then instead of, as I normally would have done in the past, said, okay, now you need to lose weight, and I think you need to start exercising and dieting. Here's a plan for you that we're going to do. Instead, I said, you know, I've told you all these things today about where my concerns are with your health and how that might affect you long term. What things might you be interested in doing in the next week or two that would help improve your health? And the difference there is that I'm asking the patient what they want and what they're interested in doing rather than telling them what I want. And if I get an answer to the question that, no, I'm really not interested in doing anything right now, Doc, the next step from that is, well, you know, might we be able to talk about this again? You know, I'd like to check your blood pressure again, and could there be a time in the future that we could both check your blood pressure and talk about this? And you can continue on the conversation that way. If the patient is interested and say, yeah, you know, Doc, you've convinced me, I do want to lose some weight, the next most important pieces are getting them to go into detail using using motivational interviewing and using a set plan. And Denise, I apologize here. The slides are from an older version of the brief action planning, and there is a new version of this. So generally, though, it follows along the same lines. So you can see here, again, asking them about what you might want to do for your health in the next week or two, and this is on slide 68. Getting them to go through a SMART behavioral plan, which means basically what they're going to do, when they're going to do it, how often they're going to do it, and getting them to give you in detail. So for example, this patient today said, I wanted to lose weight and I think I should start exercising. So I said, okay, what do you mean by exercising? What is it that you'd like to do and that you're interested in doing? Well, doc, I'd like to walk. That's great. How often do you want to walk? Well, I think I can walk, probably every day. Okay, and how long are you planning to walk for? Well, I could start out with half an hour probably every day. And where are you going to walk from? Well, I live out of town, so I've got to come in and see my father, and I usually come in and see him every day. So I'll walk from my father's place in town. Once I get the details, then the thing is to ask them to get a commitment statement from them. So I want to get clear in my head. Can you tell me in detail what it is that you plan to do, just so I understand what it is that you're telling me? Okay, doc, well, I want to lose weight, so I'm going to start exercising, and I'll do it every day. And I'll walk for half an hour, and I'm going to come into town and walk from my parents' place, my dad's place. The next step is, once you've got them to actually commit to that statement that's their plan, is to find out how confident they are on a scale of 0 to 10 or 0 to 100, how confident that they are or how sure they are that they can carry out your plan. And there was some problem with that word confident, and so it can be substituted with how sure you are and that people understand it a little bit better. Where 0 is, nice try, doc, but I'm not going to do it, to 100%, absolutely, definitely, there's no question I'll come back in and do it. The key point to that is if the patient says that they're 70% confident or more, then the chance of them actually following through with what they commit to is likely going to happen. And beyond, you congratulate them, great, you've come up with this plan. When would you like to check back with me to check over on how you're doing? And what I'll often do if there's an activity involved is actually give them an activity sheet that's just basically a blank sheet where they write down what they're going to do, and on each day, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday, they write in how long they did it for, or we'll put a check mark in it or whatever. So we'll write, in this case, walk, and I'll put in the little brackets, 30 minutes daily from Dad's place. And then each week have that. And it's just a little blank chart that I use all the time and print out for them, and they take it home. And I tell them to put it in the most obvious place that they'll always see, which is, anybody's guess?
On the fridge.
On the fridge, you got it. Exactly. Use the little magnet, put it on the fridge. And it's surprising how well that works there. And then we follow up. There was a question in there with the follow-up and I think it was, who was it that had the question about the follow-up about the MOAs? Was it you, Sharon? What was your question, Sharon, about that?
Well, I just wondered how you do that, how you manage the follow-up, because that can be quite time-consuming. In a busy clinic, it's to have people coming back in 2 weeks for a follow-up on their goals. Now, I know sometimes you'll say, do you have a friend who can support you in this, and will you, to go to the friend. But not everybody has somebody that is a good support system outside of the office. So do you have your MOAs trained in BAP, or do you do it all yourself?
Right now, I'm doing it all myself. I do have a family practice resident, as I mentioned earlier, or I may have, no, I mentioned with some other. I'm mixing up my meetings. Sorry about that. But I do have a family practice resident that we're using this as her research study, who does a lot of the follow-up as well. And I use email, and some people are recoiling in horror, but I have a specific clinic email that I can use. There's no payment for that. And I also use telephone follow-up. And there is a payment plan for that now with the GP for Me, that we have 500 telephone calls that are available to us for a year that we can, per year, that we can use to follow up with patients with chronic disease conditions. Recently I've been using some telehealth as well. There's a couple of companies out there that have private, secure telehealth plans, and the one that I'm using, I can phone up a patient and actually get paid actually more than what a visit in the office is, which is kind of scary. And we'll see how that all works out long-term with the ministry. Some it's that, but mainly I have them come back to the office. And no, I haven't trained my MOAs yet. But the chronic disease management nurse that's in our office times uses this technique as well. So because we're all consistent in using this, it doesn't necessarily matter who follows up with the patient. It's just we're following the same approach.
How do you feel the emails do work?
I have no troubles with emails. My patients in general are very respectful of them and don't misuse them. And I get a lot of information from emails, surprisingly, especially from my borderline personality patients, because I've informed them ahead of time that I won't necessarily respond to their emails, but it becomes a place that satisfies their need for reassurance that I'm not abandoning them. And even a very brief, yep, I got your email, is fine. Two things are important with the emails. One is that the college and the CMPA have an email consent form. So any patients that I'm communicating anything medical about, I use the consent form that they have to sign before I'll communicate with them. And second is that I cut and paste my answer and the patient's initial email into my EMR, and it's very quick, and I just have a template for it, and so it's recorded there so that an exact documentation of the communication is in my EMR, which is better than the telephone conversation documentation. So it works for me, but not for everybody. My patients aren't intrusive with it, which is good. And even, again, with my borderline patient, one patient that has emailed a lot, she knows that I am not necessarily going to respond. However, it's a great way to keep track of what she's up to, including that she's cutting or doing other things, and a great documentation of her state of mind at any one time. So
even though you might not respond, you would still cut and paste that into the EMR, and then when she comes in, you could review it with her. Exactly. Oh, that's really a good idea.
Bruce, would you mind telling us again where you got the consent form for the email?
It's, I can email it again to anybody who wants it. It came from the Canadian Medical Protective Association website and or on the BC College of Physicians and Surgeons website.
That would be great if we could all get that.
I will make sure, I'll send it to Sarah, and then Sarah can send it out to everybody. And I'll send everybody the most current form, which is a 4-pager on the brief action planning. The really interesting part in the brief action planning comes if people have a confidence level of less than 7, and that's where it gets really interesting in what we should say. So for example, if someone says to me, well, you know, about 5 or 50% likelihood, I'll say, well, that's great. You know, that's a lot better than 0, And that's a great sign that you'd like to do something and have a plan. What do you think you could do that would increase your confidence? What could we change that would make it more likely, that make you more sure that you could actually carry out your plan? And so then it becomes a little bit of a negotiation. Well, yeah, you're right. I don't think I could probably walk every day of the week. Maybe 5 times is more realistic. Or, maybe not 30 minutes, maybe 20 minutes is more realistic. And again, then checking back, okay, can you tell me again, give me the whole plan? Yeah, okay, I'm going to walk 5 days a week, 20 minutes a time from my dad's place, I'm going to walk. How confident are you that you can do that? Yeah, now, I feel a lot more confident. It's 80% chance I do that. Great. Now you move on with the action plan. One piece that's missing from any of those things and gets back up to the top part of the little menu there, it's talking about behavioral menu. If someone says, if I ask, is there anything you'd like to do for your health the next week? Yeah, I'd like to do something, but yeah, I don't know what I'd like to do. You then ask their permission. Would it be all right if I told you about what a couple other patients that were in your position had tried? And if the patient says, yep, sure, no, that'd be great, I'd like to hear that, then you can describe, well, I had one patient that's quite a lot like you that really liked walking, and this is what they did. And then you move on from there. So it's a whole sort of scripted but structured way of working with the patient and being able to clarify what it is that they're doing around a goal and self-management. And I use it at least 2 or 3 times a day. It takes about 3 minutes to do. I document it. Every one of in my EMR, my default SOAP note, which is a subjective objective assessment and plan note, I have a little drop-down template that I click on when I think, yep, this would be a good point to do brief action planning for whatever reason, that I click it and I can record the who, what, when, why, where, and record the confidence and record the follow-up plans for it. And so it's right there in my face anytime I'm seeing a patient, which works very well. Very useful, and I can forward it to all you that you can take a look at if you're interested. Were there any questions around that?
It sounds a lot like almost like the positive visuals. That was another PSP program that I'd taken part in. Well, yep. We've taken that information into our EMR that we do use for behavioral therapy.
Right. Yep. And it's all part of behavioral therapy, and it's a simple thing to do. And again, just some pieces that I went through in here, looking at the different choices that people might make and having that SMART behavioral plan, getting that commitment statement, making sure that the patient has an opportunity to state what they're going to do, and then problem solving for that confidence level less than 7, and exactly the steps and the things that you might say during that, and then when the follow-up is going to be on that. And putting it all together when the follow-up is again scripted, how to go with your plan, different things to do, whether there's full success, partial success, or little or no success. And I make sure with my patients that I'm talking to them about, this isn't about being good or bad, or successing or being successful or failing. It's about identifying the things that you need to do, you want to do, and whether or not there's any barriers that you found in trying to do those things, and how we can work together to overcome those barriers. And that's very reassuring to patients, that when they haven't succeeded, that you reassure them and keep moving on to deal with the barriers they might have identified. And so putting it all together, I'll send that out to Sarah, who can send it out to anyone who's interested in it.
Yeah, I'll send you a snippet about everything.
Great. So finally, in just summary, there's a couple of tips and things in there. We've come to the end. That's a lot of stuff that we've gone through. Again, everything that we went through in the last 2 3/4 hours has been what was covered in 2 full days of Train the Trainer. My mouth is dry. I hope that everything there has helped explain to you what's been covered. Some of it may not be new. And again, we really would appreciate anybody's feedback on specific tools. Manoj, thank you very much about that piece about the red flag, and the other piece that certainly was controversial about the morning stiffness being 30 or 60 minutes. We'll clarify that, and all your other comments are very much appreciated in there. Did anybody have any questions, any other comments? Did we cover things too much, too little? Sarah will, I hope, maybe get some good feedback from you on that. Some of the way that we've, pardon me?
We'd be very grateful for feedback.
Great. So, I hope that this is something that you can take. Even the way that we presented all this material might be something that you can use in your learning sessions to go through what's a lot of material and condensing it in a way that makes most sense to people. Any other comments?
Bruce,
Just out of curiosity, just a quick question. I'm looking at your presentation that you have online. Do you have any slide notes that go with it?
When I've tried to do that before, it hasn't worked very well for me because it just then doesn't sound natural, and I use the slides to try to trigger me from my own experience. And I know that's challenging to some people, but I find presentations work best when you can do it as naturally as possible.
Fair enough.
It's Lisa here. We also have not finalized all of the content for the module. We will do that based on the feedback at the Train the Trainer 2 session on October 23rd.
And this session has been recorded as well?
It has indeed. So yes, we will send out the recording.
Okay, that's great. Thanks.
Bruce?
Yes.
This is Denise. I would like to first of all thank you. I think you've done a wonderful job of summarizing a lot of material, and we have a fairly large contingency of people from the north. So from all of us, we are very, very grateful for the time and effort you've put into this. And I think you actually have left us with a really good summary tool to use, as you say, in learning sessions, as and where we need it. So thank you for that too.
Good. Thanks, Denise. Well, I promised myself that I would make sure that I was done before the 3 hours are up, and we seem to have, I set my goal for myself, and I was 80% confident I could do it, and so I did it, and I'm patting myself on the back and deciding how I can set my next goal. And so my next goal is to make sure that I send Sarah those things that I promised, and I will do that right as soon as we hang up from here. So thank you very much, everybody, and go enjoy the sunshine. I hope it's as sunny where you are as it is here.
Can I ask a question? Just is the second session, did I hear it's October 23rd?
That's correct. It's at the Western Walls Center Hotel in Richmond, and we will ensure that both Jenny and yourself will be on the invite list as well. We'll send a registration
October 23rd. Okay, all right. Okay.
October 23rd. It should be a Wednesday.
Oh, it's in the evening?
It's all day long. No, it's during the day.
Oh, all day long. Okay, yeah. Okay.
Yeah, all day long. It's a one-day session.
Right. Okay.
And we will have Dr. Hamilton Hall there for a couple of hours, I think.
Okay. Yeah. Thank you.
And we'd like to thank you, Bruce, for quite the marathon session, and it didn't feel that long at all. It was very good, very great. Thank you, Bruce.
Okay. Thank you, everybody.
Yeah. Thank you.
Thank you, Bruce.